Our main speaker today is Brent James, who is a cancer surgeon by background, an academic cancer surgeon, who is now the Chief Quality Officer of Intermountain Healthcare, which is a not-for-profit healthcare system about twice the size of NHS Lothian in Utah in the United States of America. He's also the director of their Institute for Healthcare Research Delivery, and he's a world-renowned expert in quality of care and quality improvement. And part of our approach in Lothian with the Clinical Change Forum has been to engage with our own senior clinicians to help us respond to the huge challenges we face. But it's not just about internal engagement, it's very much about reaching out to learn from other high-performing healthcare systems across the globe. And there's no better example of that than Intermountain Healthcare and Brent James in particular.
For me personally, I found from day one Brent and in fact the entire team at Intermountain inspirational. I knew after day one that we should try and get him to Lothian. I knew after week one that we definitely had to get him here. We are really lucky. He does not travel internationally a lot these days. The fact he's given up 3 days of his time to spend with us, I cannot tell you how delighted I am personally, and hopefully this will be the start of a great partnership for us in Lothian. I'm just truly delighted.
We put together a care management system. It's built around clinical processes. It's been associated with dramatic improvements in clinical outcomes. I can document about 2,000 lives per year in the Intermountain system of people who a few years ago would have died who don't today. And as you understand, mortality is kind of the tip of the iceberg. Dramatic effect on suffering averted, on function restored. That's been associated with equally dramatic reductions in our cost of operations. We documented through last year $440 million in savings through waste elimination within the Intermountain system. That's about 10% of our total cost of operations. Our goal by 2016 is to take out $700 million, about 15%, and we're on track to do it. We believe that care that is not accessible, by definition, is low quality. And accessible means affordable. Now, most often, higher quality means lower cost. And I think that we've understood that principle, we've applied it broadly. We do not save money by rationing care or by queuing patients. We save money by eliminating waste and delivering better clinical outcomes.
One of the workshops that I was in today made special reference to stroke and stroke pathways. And what was very clear from the data that had been collated was that we have process, but the process we have is different in each of the 3 sites, when actually that data tells us it should be the same thing, it should be the same journey.
Hearing what I've heard today, there's clearly quite a lot of variation that can occur, and it's quite clear that to get absolutely the best quality of care, we need to really be driving down the variation.
We have a method for identifying, measuring, then managing clinical care delivery that makes those processes of care transparent to clinicians, physicians and nurses, and to the patients that they serve. That transparency makes it easier to do it right, and nearly always results in significant improvements in clinical performance. That forms the framework for systematic improvement, for a learning healthcare system where you can learn from every patient so that we're better tomorrow than we were yesterday, and far better in a year or 2 years than we were a few years ago.
So I've just finished my Scottish Patient Safety Fellowship, which is all about quality improvement, and I've had a hugely inspirational year doing that kind of work. And one of the most exciting parts of that journey was sitting in the second clinical change cabinet with my colleague who was also a fellow in that cohort, and suddenly hearing about what we were going to be doing within NHS Lothian. It was hugely exciting to be part of that journey right at the end of our training.
The Scottish healthcare system has a wonderful international reputation. I first heard about it from your patient safety fellows visiting, people like Derek Feely at the Institute for Healthcare Improvement, showing me some of the things you've accomplished. I've come to regard you as one of the better systems, certainly in Europe, and a colleague on a similar path, a similar journey. Anytime you have good systems addressing similar problems in different environments, there's a wonderful opportunity to learn from one another. So I'm as interested in learning from you as I am in sharing some of our experiences. That's how we both get better.
Today's lectures brought it home to me that we have quite a lot of systems for quality in general practice already. So we've got QOF, which is all about some of the standardisation he talked about, very evidence-based. There's lots of initiatives that we have around prescribing, quality, referrals and so on. But I think a lot of the quality that we have in general practice is generated within our partnerships, where we're focusing on our teams, on our relationships, on the service we provide patients, and things like how we consult with our patients and how we explore their feelings about what's wrong with them and understand them better. So I think it's quite a wider definition perhaps than we've heard today.
There were aspects of what he was talking to us about. If we were to just take it forward a bit more, we would achieve it. We're actually doing some of what he was suggesting we should be, but maybe not to the depth and maybe not in the whole round. I think it's achievable.
It's consolidated what we know and what we've learned over the last year, but the kind of excitement about it is the fact that we're going to be able to do it within our organisation. It's not something that we're going to have a little bubble around in our training and then come back and struggle to implement with that shared vision within the organisation. And for me, that's the most exciting part.
Quality is in some senses the holy grail to me. I think it's what everybody strives to reach certainly within the NHS. It's difficult to define because it varies, and it varies depending on which system you work on, and it varies from one patient to another. But quality is, to me, the consistent delivery of a high quality service, an excellent service, a service that my parents would like, or my brother or my sister would like, the standard of care that I would expect to receive.
Well, there are lots of different definitions of quality, and the NHS Quality Strategy has the 5 dimensions of quality. But for me, fundamentally, it's about, number one, getting the best possible outcome for patients. But also allied to that, it is at the least possible cost. And that's simply because we need to make our resources, both cash and workforce, go further than ever. And so how do we do that? Is the best possible outcome at the lowest possible cost means minimising waste, minimising unwarranted variation, minimising inappropriate or unnecessary treatments or investigations, and of course also one of the principal tenets of the Scottish Patient Safety Programme is minimising harm to patients, whether that's by patients contracting infection in hospital, for example, and all of the outcome concerns and costs associated with fixing things when things go wrong. So getting it right first time, every time, is the maximum that quality is trying to secure.